sorry. Today is National Vietnam Veterans Day. 50 years ago today, the U.S. Military Assistance Command Vietnam disbanded and combat troops departed. The last of the acknowledged prisoners of war in Hanoi also were released. It is fitting that we are holding a hearing on the Department of Veterans Affairs budget request for the fiscal year 2024. More than any other federal department, the VA recognizes, supports, cares for, and lays to rest our nation's veterans. We appreciate our Vietnam veterans. We are, at least I personally am very sorry for the way they were treated when they came home. And the VA's efforts to honor their services is very important to me. The Secretary, Mr. Secretary, welcome, and thank you for joining us today. We appreciate your leadership and the department's effort to support veterans. I have 3 comments about the budget request. First comment is Congress has always prioritized veterans and will continue to do so. I anticipate we will fully fund veterans health care and other programs for FY24. Second, VA's $20.3 billion request for the Toxic Exposure Fund is not credible. It is contrary to VA's promises during the consideration of the PACT Act. It shifts more than $14 billion from discretionary to mandatory spending, and this is not okay. The administration is using veterans to increase spending not related to defense or other veterans programs. And despite all our serious problems with spending, inflation, and national debt, so we all want to care for veterans exposed to environmental toxins, but let's be honest about it. And its cost and its approach, and be transparent in that approach. Third, this committee continues to support interoperable VA-DoD electronic health records. To achieve this, the VA must make the new system work for providers and veterans. This includes holding Oracle's Cerna to its commitments. And before I close, I want to thank the VA Congressional Fellowship Program. I'm honored to host fellows from the VA, and I want to highlight the great work Jasmine Guion this year. Like all the fellows who preceded her, she has a tremendous work ethic and a can-do spirit, and provides valuable insight into veterans and the unique needs of veterans. In a few months, she's been here. She's become a critical member of my team. No, you can't ever. Not until your time's up, anyway. Mr. Secretary, thank you for being here. I recognize my ranking member, Ms. Wasserman Schultz, who is a good partner in this job.
Thank you.
I'm glad to have her.
Thank you, Mr. Chairman. Thank you, Mr. Chairman. Welcome, Secretary McDonough. Good to see you again. We appreciate you hosting us the other day. I'm sorry you couldn't make it, but I stood in for you and told them everything that needs to happen, and that you were right there with me.
Okay. Well, you talking about breakfast?
Yes.
Well, let me apologize about that.
No.
I had surgery 2 days ago on my head, and I thought it was a minor surgery, but I was under somewhere for 4 hours.
Hey.
And so I just couldn't I needed to rest.
Yeah, no, absolutely. I was not raising that. I was just teasing you and not raising that for any other reason.
Oh, I know that.
So I am also pleased to welcome you back, Mr. Secretary, to the Milcom VA Subcommittee. And we're looking forward to hearing from you about VA's budget request, which totals for FY24 $318 billion. Within this amount, the budget requests almost $138 billion for the discretionary programs of VA and $180 billion in mandatory funding for veterans benefits and for the cost of war toxic exposure fund. I'm pleased to see the administration using the full authority of the Toxic Exposures Fund in its budget requests, and that's exactly how we intended the VA to use it. Very specifically, in contrast to what the chairman just described, $20.3 billion in mandatory funding through the Toxic Exposures Fund ensures our commitment to the PACT Act and to our veterans. The funding specifically will support claims processors, appeals, IT investments, critical research, and of course the healthcare costs for veterans exposed to burn pits, Agent Orange, and other toxic substances. The reason we created that fund, and we did agree, and as did the administration, that we would limit what would be spent from the Toxic Exposures Fund to expenses related to implementing the PACT Act. So there's no bait and switch here. It's very clear and very narrow. Once again, your budget breaks out VA medical care as a third budget category. The intensity and reliance on the VA healthcare system coupled with medical inflation is consistently driving the ever-growing funding requirements of VA medical care. The unique nature of these programs requires VA medical care to be considered separately from other non-defense discretionary funding. That third budget category will ensure that funding for veterans' health care will always be taken care of, so veteran health care is not pitted against other non-defense discretionary programs. I fully support the administration's request for a third budget category, and I urge my colleagues on the other side of the aisle to thoughtfully consider this concept as well, because it's the best way to take care of our veterans. One of the challenges that I know you're aware that we have is that, it's not just medical care that veterans access. I mean, there are all kinds of other programs across, even elements, programs at the VA that are not directly related to health care that veterans need to be able to access. And we can't have the increased costs in discretionary chew up all of the ability for us to provide funding for those vital programs that veterans need. So diving into the details a bit, this budget request continues to invest in veterans and will support high-quality care and high-quality facilities. Women veterans are the fastest growing population, accounting for 30% of the increase in veterans served at the VA over the past 5 years. 627,000 women are using VA services, and that number has tripled since 2001. This budget continues to support health care and programs unique to women and expand their access to care, and we thank you for that. Additionally, VA continues to prioritize access to mental health, including suicide prevention initiatives, as well as strong investments in homelessness prevention, opioid abuse prevention, and focusing on taking care of the whole veteran through the whole health model of care. I'm proud of the targeted investments we've made over the last 4 years to increase access to VA for all veterans, and this budget request continues to build on that progress. But what does concern me is Republican leadership's public promises to limit discretionary spending levels to FY22 levels. If those go through with these reckless and draconian cuts, the impact on our veterans will be devastating. VA would only be able to support 126 million outpatient visits at those levels, which is 13 million visits or 9% less than VA's projections for 2024. Wait times will increase and veterans won't be able to access all the care that they need. Telehealth services will be restricted, which will particularly negatively impact our rural veterans. The claims backlog will continue to grow and veterans would have to wait even longer to receive the benefits they've earned. Critical research will be curtailed. Even if the cuts are limited and do not touch VA healthcare, all of the items that I just mentioned would be impacted. And I could go on, but suffice it to say that there are real-world impacts on veterans' lives when we are looking at underfunding VA by almost $30 billion. Even if there's a world where funding for veterans' health care is held harmless, that would only further devastate the rest of the non-defense discretionary programs that veterans rely on outside of VA, like homelessness programs, job training, employment resources, transportation resources. This is not a game where we go through a cuts exercise trying to get to some arbitrary number. This proposal to cut VA programs back to FY22 levels plays politics with veterans' lives. I am glad the other day at our previous hearing that some of my colleagues on the other side of the aisle did speak up and say they were not supportive of those proposals. I hope that holds true as we move forward, and I urge my Republicans colleagues to take a step back and look at the real-world human impact of cutting back to FY22 levels. We have a lot of ground to cover today, and I look forward to your testimony, Mr. Secretary. Thank you, Mr. Chairman. I yield back.
All right, listen, you submitted your written testimony. We thank you
Yep.
for that. And around 5 minutes is what we'd like you to use.
I'm gonna get right at 5.
To the floor.
Okay.
So, okay,
All right. Well, I'll hit the target here.
okay, very good.
Mr. Chairman, Ranking Member Wasserman Schultz, distinguished members of the subcommittee, including the new members of the committee, thank you all very much. It's nice to see you all. VA will be strengthened by this committee's work, as it always is, so I attach great importance to our relationship. And I pledge to you, each of you, my candor and my transparency on these matters. 50 years ago today, a Minnesotan named Master Sergeant Max Bielke climbed aboard a C-130 and left Vietnam, the last American combat trooper to leave the country. And his service didn't end then. After retiring from the Army and after having served in both Korea and Vietnam, Master Sergeant Bielke spent the rest of his life serving, advocating for fellow vets and their families. And he died serving vets, serving this country. He died when the plane hit the Pentagon on September 11th. The last one to leave war, he was the first one to die in a new war, the longest in American history, which many of you had a personal role in. So today and every day, we honor the immense service and sacrifice of all Vietnam vets like Master Sergeant Bielke, and the privilege of caring for the brave men and women who have fought our nation's wars over the past 5 decades, those standing guard today, and their families, survivors, and caregivers will continue for decades to come. America made them a promise, and it's our job to keep it. So we will collaborate with you as effectively as we can to build on what's working for vets and to fix what's not. Today, VA is delivering more care and more benefits to more veterans than at any time in our nation's history. Vets had over 115 million clinical encounters in the past year, nearly 40 million in-person VA appointments, 31 million telehealth appointments, and 38 million community care appointments. On benefits, we set a record with over 1.7 million claims completed last year, and we're on pace to break that record this year. Since the PACT Act was signed last August, veterans and survivors have filed more than 1.25 million claims. That's a 27% increase on the same period last year. Vets deserve our very best, and with this budget, we can count on serving them as well as they have served us. The budget request is a $325.1 billion, the largest investment in U.S. history for vets, their families, caregivers, and survivors. This year alone, it will mean 411,000 vets attending their first VA healthcare appointment, joining the approximately 9 million other vets already enrolled. 308,000 vets and 56,000 family members receiving their first earned benefits payments, in addition to the 7 million we currently serve. And over 140,000 veterans and family members being interred in a dignified, lasting resting place. This budget's about more than numbers. It's about preventing veteran suicide, our top clinical priority, which gets $16.6 billion in this budget. It's about ending veteran homelessness, which gets $3.1 billion. It's about supporting health care for women veterans, which gets over $1.2 billion in this budget. And it's about restoring VA's severely aging infrastructure. At nearly $10 billion in investment, this budget recognizes that the traditional approach to infrastructure funding has fallen far short of providing veterans with modern environments of care. No investment is more critical to our success than the investments in the people we hire and retain at VA. So we are increasing hiring, quickly onboarding staff, and incentivizing retention. We hired more staff at VHA in the first quarter of this year than in any previous year. I'm proud to report that we hired 2,465 registered nurses, 465 licensed practical nurses, and 788 nursing assistants. We have hired more people in these three critical occupations than at any time in the past 20 years. Overall, we've onboarded nearly 23,000 new hires this year, on our way to our goal of 52,000 new VHA hires. VBA's been holding regional hiring fairs to interview thousands of applicants, and we extended same-day job offers to nearly 1,100 attendees, putting us on track to fill all of the 1,871 authorized PACT Act positions. These positions will translate into more benefits. This past week has set new records in delivering benefits for veterans. Our VBA team has completed over 8,000 claims every single day since March 20, far above last year's record daily output. That's a testament to our incredible VA team, the best workforce in the federal government, and we're reminded today that VA is among the best places to work in the federal government for the second year in a row, a fact of which I'm quite proud. That workforce of which I'm talking includes people like Navy veteran Krishan Lloyd, a corpsman who medically retired last year. We hired Krishan earlier this month at the Chicago Regional Office Hiring Fair to serve vets as a Veteran Service Representative, a VSR. Krishan said he remembers how thorough, responsive, and caring his VSR was as he transitioned from the Navy, and that he, quote, couldn't imagine a more rewarding career, serving his brothers and sisters in arms in a mission that is so deeply personal. That's the kind of deep devotion that characterizes VA's people. Thank you, Mr. Chairman. I look very much forward to your past as prologue, given earlier data, lose more women vets, meaning keep fewer women vets in our care. And then if we go back to the 2022 levels, new legislation enacted since 2022, including what's called the Service Act, which covers breast cancer risk assessments for eligible veterans, would be negatively impacted. At the moment, we only have 80 sites in VA that provide mammography on site. That means we're referring a lot of mammography into the community, which is a good and decent thing. But over time, we know that women veterans stay with us, the more access they have to gender-specific care. The 2022 level funding would put that at risk.
Thank you. Yeah, the next part of my question was related to the Service Act. My understanding is you're projecting that an additional 52,000 breast cancer risk assessments across all sites in 2023 would take place. What kind of increase is that compared to what VA had previously been doing?
Well, because
And
this,
also, what kind of outreach is VA doing to let women know of these expanded mammography screening services? I know when I visit VA facilities that don't have those kinds of services, the women veterans always mention to me, we really need broader services, mammography here, and so.
yeah. Well, as we have increased over the course of the last 6 or 8 years, gender-specific care, we're able then to provide the full range of services for women vets. A good example is right here in Gaithersburg, Maryland, where on the same site we offer primary care, mental health care, gynecology, and on many days access to child care, which is meaningful obviously for both male and female veterans, and then mammography. So rather than traveling throughout suburban Maryland, a woman veteran can get all of her integrated care in one stop. Then as a result of that, we've seen substantial increase in mammography screenings over the course of the last year. I don't have a specific number, well, I'll get that to you. And obviously the connection between early detection and prevention is well established. So we think that things like the Service Act, and look, that's why we've seen legislation, new laws like the Service Act, like the PACT Act, like the Mission Act, were anticipated to increase costs, have commensurately increased costs, and that's why we've seen the increase over the course of the last 6 or 8 years that we've seen in VHA.
Thank you, Mr. Secretary. And Mr. Chairman, I know you know that this is an issue is very personal to me as a breast cancer survivor. I am here today because I was able to detect my breast cancer early. Had my first mammogram, came back clean. A few months later, I found a lump myself because my antenna had been raised to focus on my breast health, and the ability for women at the VA to get one-stop shopping and increase mammography care specifically, instead of having to go around and make it much more difficult to get different kinds of health care in different places, make it less likely, if that's the way they have to get their health care, that when they do have an illness like breast cancer, that it's going to be caught early. And then they have more complicated health care challenges, and are more likely not to survive. So I commend you and all of the folks at the VA for moving in the direction you are. Thank you. I yield back.
Mr. Zinke.
Thank you, Mr. Chairman, and thank you for your service. I know you have a difficult task. So if I could, I'm going to go through some issues that have been brought up to me as I travel around the state. Thank
Great.
you. I visited the VA facilities, both clinics in Butte, Missoula, and Billings. They're magnificent and they're quality facilities, and I commend you on that. But as I go around, what I'm hearing is it your policy of the VA that a service member who is not fully vaccinated Can he go to surgery? Because what I'm hearing is, in some cases, a veteran is not fully vaccinated, can't get an organ transplant and go to surgery. Is there a VA policy that puts up a barrier for someone who chooses not to be fully vaccinated?
There's not, and if there's a specific concern, let me go to work on it. But we do have a vaccination requirement on our workforce.
On workforce?
We do not on our patients.
Okay, and what I'm also hearing is in Montana and a lot of rural states, life flight, because in some cases the nearest hospital is 100 miles away. It
Yeah.
could be more, and by the time you run up on an accident, you're already behind the power curve. And are you aware that there's a change in policy on reimbursement, historical?
Yeah, we just went final with a rule. The rule was first proposed in 2019. There was several years of comment taken. The rule was proposed in the first instance because VA has been found wanting by the Inspector General in our policy, because there are several VA facilities and systems that, unique among any healthcare system in the country, pay delivery by delivery rather than pursuant to a contract that's negotiated in the local market.
But my understanding is you're going to exempt the contracts from CMS. Is that right?
No, so what the rule proposed, what the rule
from
now
their
does-
schedule, from the CMS schedule, you're going to exempt them through a contract.
what we say is the rule says the following: if you are a provider that provides this service, we will pay you either what we've negotiated with you in the contract, or if we have not been able to negotiate a contract with you, we will pay you the CMS reimbursement rate.
And I think the crux of the climb is we need help on delivering the contracts.
Exactly.
Because they do not have whatever we need to do to expedite the contracts, because it seems like the bureaucracy is behind it. And unfortunately, in rural America, a life flight is the
I hear
only
you.
option for
I hear
veterans.
you.
So
So we,
I have your commitment to work on that.
absolutely, absolutely. And the rule envisions, the final rule envisions a year during which the existing system continues, and then we have that year to negotiate contracts with providers. And again, we at the moment, I'm told, we're the only hospital system in the country that pays incident by incident. And as you can imagine, that's not a great deal for the taxpayers. So we want to get to a contract which will be fair and negotiated per each local market's needs by the local market and the local provider. This is not something for us to do. This
so-
is something for the hospitals.
Shifting gears on elective surgery.
Yeah.
Do you pay for sex change operations, either gender therapy, sex change operations in that category?
Yeah, so we provide a full range of gender.
Lifetime care?
Well, yeah, that if somebody is
I'm
enrolled.
not an expert. My
yeah.
understanding, if you
So if
you
you're
choose, you have a
enrolled-
lifetime of care with gender therapy and all that process.
Sure, hormone treatment, for example, or, so, and we have made clear as of 2021 that we're in the process of establishing rules to provide gender-confirming care itself at VA.
And I haven't looked through your budget. Did you ask for additional
No,
on that?
no, we did not.
And what do you spend on that?
I can get you a number on in terms of what we care, any care that we provide now for gender-confirming surgery would
you
be
consider that a
referred to the
priority?
community.
I'm on the VA task. Would you consider that a priority?
The reason that we started the rulemaking process to offer it directly in VA is that there is a direct correlation, and this was a uniform consensus recommendation to me from our care providers. The reason they recommend we do it, the reason why I think we should do it, is the connection between mental health disorder, including suicide, and what we call, what clinicians call gender dysphoria, is a very tight connection. Meaning, the extent to which we treat a veteran experiencing gender dysphoria reduces risk of suicide among transgender veterans. Inasmuch as suicide prevention is our #1 clinical priority, yes, I consider it a priority.
Thank you. Mr. Chairman, I yield back.
Ms. Lee?
Thank you, Mr. Chairman. Thank you, Ranking Member Schultz, Wasserman Schultz, and Secretary. It's great to see you.
And you?
You touched on in your testimony about the staffing shortages and the progress you're making. We know in Southern Nevada it's still continuing to be a problem and long wait times. And in fact, in February of this year, they just did a job fair trying to fill 200 positions. Our VA team in Southern Nevada says that part of the problem is just simply the HR process within the federal government, specifically in the onboarding. It can take up to 2 months just to post an opening from the time that an employee leaves, and then another 6 to 9 months to onboard. That means it can take almost a year to bring a physician online. It seems like you're aware of that, but what do you see as the main barriers to accelerating this process?
Yeah, so it is a crazy and 100% indefensible where we find ourselves in terms of onboarding. We're getting better at hiring. So the first question is the one you raised, which is why can't we sometimes know when a person is leaving. Why can't we post then? So we're working through that.
Okay.
The posting is going to be resolved. The hiring, we're getting better at, using things like hiring fairs and using the authorities that you've given us, including in the PACT Act and the very generous appropriations that this committee routinely gives us. We are very competitive, and what we're seeing, including, I heard this first in Nevada, we are now seeing nurses who had left us to go to the community and specifically to traveling nurse teams coming back to us because of our practices and because of our competitive salaries now. So we're getting better at hiring. The thing that we are spending this year prioritizing is reducing that onboarding time. So the main issue there is there's about 12 steps in onboarding. We need to contract some of those steps out, for example, drug testing. We need to, most importantly, get better at not making every individual nurse or doctor responsible for their 12 steps. There should be a technology solution that allows us to click through those 12 steps very quickly. We've, just used brute force in various hiring fairs to get that done in one day in places. But in too many places, it's like Southern Nevada, where somebody gets an email, it goes to spam. They actually didn't know somebody was contacting them to get the next step in that multi-step process done. There's a technology fix here. There's a people fix here. And I pray to God the next time I appear before you that we've reduced this number, because if we don't, we won't meet our hiring targets.
Is there anything that we can do in Congress to help expedite?
I think you've given the most important thing you have done to date helps, which is making us competitive. We are working with the authorizers to address a particular problem we have with certain specialists who are topped at $400,000 a year in their pay. We think that requires an authorization fix. I hope we'll get that. It creates a major problem, which is, for example, gastroenterologists right now, a very tight market. We can't hire them unless we pay them $400,000 a year. Very few are going to take that kind of level pay. So what we're doing now is we're paying contracts for up to $1.2 million a year to get access to some bit of that person's time, rather than being able to hire them to get them full-time. Mm-hmm. This change at the Authorization Committee will help us to address that.
I want to turn to the EHRM.
Mm-hmm.
You all requested $1.9 billion. As we're all aware, there's been many issues with the rollout.
Yes.
Driving, great dissatisfaction, some staff shortages as a result. I know you all have been tracking this closely. Can you just offer us an update and how this request will help get it back on track?
Sure. Let me just say first on where we are in a very important thing, which is it's a 10-year contract. We're at the 5-year mark. It envisions at the 5-year mark a relook at the contract. We're in negotiations with Oracle Cerner right now to successfully deploy a fully functioning system within 10 years. The way forward is heavily dependent on the result of these negotiations. VA requires something we've not yet had, which is an efficient and properly functioning system all the time across the system. And at the end of the day, the vets don't really care which
Right.
technology we use. They just want to make sure that we can deliver what we promise. So the first and most important thing is these contract negotiations are very critical to that. And second, the budget that we have submitted, importantly, positions us, provided we get the contract that we need and the performance standards that we're going to require of the contractor, allows us to invest in the out years, including on upgrading facilities. Nevada's relatively early in the process, so one of the things that we have to do is make sure that the next deployed sites are ready to receive the new technology, and that we have the training manuals and everything in place to do it. So the budget will allow us to do that, even as we take the results of this process that we've now just completed, which is an assess and address period to assess what has happened in the 5 facilities where we have deployed it, and then address the shortcomings that we have before we deploy to the next onward sites. So again, depending on what happens in the contract, we'll be in a position to deploy to next sites based on the generous appropriation from last year. Again, if we get the contract we need here, this budget will get us in a position to continue the investments to make the next deployed sites ready and ready to receive the new technology.
Okay. I think my time's up. Is that right? Or do
You can leave for just a minute.
sure.
Where's the next deployed site?
The next question is going to be around Saginaw in Vision 10, Michigan.
Okay.
Okay.
Thank you.
But that's a decision we've not yet made. We'll make that based on where the technology is. But to be honest with you, increasingly my question is, I need to see what happens in these contracts before we make a decision about where we go next anyway, because the contract may be not what we need.
Ms. Bryce? Oh. Oh, you have one more
Just
question?
if you're not in the contract negotiations, is there a potential you change contractors, or what's if
Well, I
you
think
do not
in-
get
in-
what you want?
Obviously inherent in the idea that there's a 5-year review is that, you're not just reviewing it to continue it. So,
Right.
We'd have to, we'd be in a position to sustain what we have and then see if there's another technology.
Okay, thank you.
Ms. Bryce?
Thank you, Mr. Chairman and Mr. Secretary. It's great to see you again.
Nice to see you.
I want to start by saying that it's an honor for me to represent Oklahoma's 5th Congressional District with close to 50,000 veterans who reside in my community.
And fast growing at that.
And very fast growing. We support veterans in Oklahoma. I want to also thank you for visiting Oklahoma City, the medical facility and service facilities that you were able to see there. Our local VA director, Wade Vlasic, is really doing a tremendous job. And I'm glad you're able to see the people and the facilities firsthand, as well as some of the challenges that we face. Ms. Lee brought up the medical professionals, and I think that's a really important point. You mentioned in your comments that you've had great success in hiring nurses. What is the physician shortage that you currently have across the VA? Do you have a perspective on that?
Yeah, well, I can get you the specific data about where we are across the system. But, we have particular shortages in specialties, which is true in many healthcare systems. We have particular requirements for psychologists and psychiatrists.
And I would assume they're hitting that $400,000 cap as well.
Yeah, but and we're able to pay them. It's a certain segment of specialists that are stuck under the $400,000 cap.
Okay.
And certain of our leaders, like Wade, who would be also stuck at that $400,000 cap. So I want to, in a very tight, very competitive market, I don't want to lose great leaders like Wade because we're capped. So network directors, hospital directors, and certain physician expert specialties, we're at a strategic disadvantage. I'll say one other thing real quick, just about Oklahoma City, because I called Wade yesterday to check in on how he's doing. Oklahoma is a particular challenge because of the very tight nursing market. I'm really proud of Wade for the work that he's doing, including significantly expanding our nurse residency programs. Our goal eventually is to expand our nurse residency programs 5x across the system. He hasn't given me a specific quantum for Oklahoma City, but unless we are involved in the process of training new nurses, we're going to just keep moving them, the limited number we have, through the system and basically paying Paul and Peter here throughout. So we're, including in Oklahoma, using the tools that you've given us to expand the training pots that we have.
That's really good to hear because you're exactly right. It's a nursing shortage across the state is significant. And I will say that in a meeting I had last week, one of the universities that happens to be very close to the VA is increasing its nursing program numbers to be able to try to push more students through the program in a faster fashion. So it's great to hear that. I want to just pivot slightly to the facility itself.
Yes.
You saw the VA facility. It was built in the 50s. It is aging. It's starting to show its limitations. I know there's some renovations that we've been doing, but I feel like this is a Band-Aid sort of fix for that. Can you talk a little bit about the process that VA uses to prioritize construction projects, or what factors would you look at in considering replacing an older VA medical facility?
Well, thanks so much. I do. Wade also told me yesterday that they're working with our region. It's called the Vision 19, on submitting a package in the near term here for a replacement facility. VA facilities, hospitals, are on average 62 years old. And I mentioned in my opening comments that the way we've funded infrastructure projects traditionally hasn't worked the way we need it to, because in the last 10 years we've only built 4 hospitals. So we have 173 hospitals. We've only built 4 of them in the last 10 years, even though the average age is 62 years.
Can you speak to why that is?
The why that is because hospitals are expensive. We have a 3-pronged strategy, and you see it in this budget. Prong 1 is major construction. That's hospitals. We're asking for enough money to invest in and build a new hospital in St. Louis this year. That's about between $1 3/4 and $2 billion to build one hospital. We also have minor construction and leases. Minor construction and leases increases access and allows us in a lot of places in Oklahoma, in each of your districts, build new clinics to increase access there. And then we have non-recurring maintenance. This year we're asking for $5.2 billion in non-recurring maintenance. That's not to add any new square footage or any new facilities. That's to make what we have workable. And so we're asking for $10 billion, the largest by an order of magnitude in any budget ever submitted by the president, recognizing the enormity of this challenge. The question then is, how do we decide among these needs what we do? We have a process called the Strategic Capital Investment Project that has a specific list every year. The list is prioritized by a range of requirements, including age of the facility it's replacing, number of vets needing care, patient safety issues resulting as a result of aged facilities, and increasingly we have built into the SCIP process a premium, for example, for gender-specific care. In those places where we have a particular need, given the growing number of women vets. Oklahoma is one of those. If you're building a gender-specific component, that's going to get a quantum to bust you up higher on the skip list. So this is a process we keep very close touch with your staff on. We'd be more than happy to talk anybody through. Mr. Guest has a question about a retirement facility in Jackson. So I was able to get that data for him. So we do this across all of our facilities, hospitals, clinics, what we call CLCs, our retirement homes, community living centers. And the process is transparent. The bottom line, though, is we need more money to get farther down the list.
Mr. Chairman, I can't see the time. I have one quick follow-up if my time allows. Thank you. You mentioned electronic health records with Ms. Lee earlier. That project is delayed and over budget. What are the chances we can get something resolved in a quick time fashion, because this just continues to drag on and it's really a disservice to our vets?
No question, a disservice, and it's a 20-year process. We decided in the early 2000s that we need this, and we still need it. So we, I want it bad, but sometimes when you want it bad, you get it bad. So we're working through this, including, as I said, with this contract. We'll talk you through the provided we get the contract we need, the schedule that will allow us to do this. We'll stay close to you guys on this. We feel deeply accountable to you for it because you've already invested several $1 billion in it. And as the chairman said in his opening comments, we too remain committed to the idea. We got to get the contract right. We got to get the execution right.
I yield back.
We have been joined by Ms. DeLauro, the ranking member of the full committee. Welcome, and we'll yield to you now.
Thank you so much. Thank you and as chair and to the ranking member for letting me dash in and dash out here. So there are about 4 on the schedule today. I will just say the first time I was in this room was yesterday. All the years I've been in the Congress, the first time I was in the room yesterday. Now it's 2 days in a row. So there's something about the room. Welcome, Mr. Secretary.
Thank
It's
you.
a delight to be with you, and thank you for your partnership over the years and working together. One of the things I want to ask about is there is a proposal from some members of the other side of the aisle to cut the fiscal year 2024 discretionary spending back to the 2022 level. And you know that I have asked all of the agencies to let me know what the consequences of those cuts would be, and you graciously replied, and you said that as I understand it, that such proposed cuts could lead to an underfunding the VA by about $30 billion. What I want to do is to say, what is the effect of of these kinds of cuts as they relate to the speed in which veterans receive their benefits, wait times for looking for benefits. How would the cuts deal with the Veterans Benefits Administration, the backlog? Are you able to estimate how many veterans would be affected by the cuts related to their benefits and their pensions as well?
Yeah, thank you very much. So last year, FY22, we provided care to more than 6 million vets, and that was about 125 million visits. I detailed kind of the breakdown. That's in direct care system, that's in telehealth, and then that's in referrals to the community. There's about 38 million referrals to the community. That's a big number, which means important outcomes. But I think one of the things we risk missing is that those are real dollars invested in healthcare providers in the private sector in your districts. So what we think is that this year's budget, FY24, would support approximately 139 million outpatient visits. And if we went back to a 2022 funding level, we might only be able to support about 126 million healthcare outpatient visits, which would be a reduction in 13 million visits, okay? So that obviously has, we fear, very, very real impact on veterans. That will also then risk wait times for the care, but also importantly, we would not be able to continue the hiring that we're undergoing at the VBA, the Benefits Administration, which we'd face at least a $409 million shortfall, which would be a reduction in about 1,178 staff who are processing claims. I said that in the last 10 days, we've processed more than 8,300 claims a day. That's a substantial increase from when I started. We used to get excited when we get over 6,000 claims a day. Because of the hiring, because of the increased efficiency, we're operating now at a more productive rate than even in 2019, so pre-pandemic levels. And we're deploying new technology, as the chairman asked about, on automation. Notwithstanding that, a reduction of that number of personnel, which is almost the same number of people that are authorized by the PACT Act for us to hire this year, we'd have to then reduce that quantum next year. That will have an impact on time to process those claims.
So you were going to hurt the benefits and the ability to be able to get care to people.
We think there would be real impacts on both.
On the construction side, if you apply the same level of cut, how does the dealing with the construction side of this future construction affect the ability of veterans to receive care? What happens with the holdup of the construction? And I'll add just one more piece to this. Look, there are some folks who say they want to shield veterans funding from any potential cuts, but sometimes that exacerbates the issue here for us, because if VA would be held harmless from these cuts, then other programs across the federal government would have to be cut. But what would be the impact of that on veterans? So impact on construction and what that would mean.
Yeah.
And then if you hold it harmless, look, we made promises to veterans. We want to keep those promises to veterans. You know, so what happens?
Well, so I was just speaking with Congressman Bice about this question of our three-pronged strategy on infrastructure. So the lion's share, the major construction request this year is about $185 billion. That's for an entirely new hospital in St. Louis. If we go back to FY22, that would be about a $565 million cut on the major construction account in FY24, which means we couldn't complete the facility in St. Louis, which means it would go on longer and cost more. We've only built 4 new hospitals in the last 10 years. There's a lot of reasons for that. Some of those are our bad execution. Denver was terrible execution by VA, and I would never defend it. But what we also know about Denver is when it drags on, it gets more expensive. Because then we have to renegotiate, and we saw that obviously over the course of the last several years with the impact on supply chain and the impact on certain price increases of inputs to construction. So that's a very real impact in St. Louis. And remember, St. Louis, we've talked a lot about El Paso. I saw Mr. Gonzalez just came in. He's been focused on this quite a bit as well. We're trying to prove facility by facility that we can be trusted with these kinds of levels that the president's asked for in $10 billion here. So the major construction, which is just one impact, would see, as I said, about a $565 million reduction. We just couldn't complete the plans that we have there. And when we don't complete them, it's not that we don't need them. It just means they get more expensive and they get dragged out. On the question of, the impact on the broader, if this is held harmless, this is really somebody else's concern, but as a member of the President's Cabinet and as somebody who oversees veterans accessing all the other supports in the federal government, Department of Education, as one example, I'd be worried about the broader impact.
Housing.
housing. We're very proud of the fact that we permanently housed 40,000 veterans previously homeless in this last calendar year. If we don't have the collaboration with our HUD counterparts, we're not going to be able to do that.
Thank you very much, and thank you, Mr. Chairman and Ranking Member, for allowing me to interlope in and out. And thank you, Mr. Secretary. Thank you for your service. Great to work with you.
Thank you, Ms. DeLauro. Mr. Valdeo.
Thank you, Chairman. Thank you, Secretary, for your time today. Nice to see you as well. I know we've talked about this many times, but I have to bring it back up again. The community-based outpatient clinic in Bakersfield, California still remains unbuilt. It's been 12 years since Congress authorized its construction, but my veteran constituents in Central Valley still don't have an updated facility. This case has been riddled with bureaucracy, endless lawsuits. Meanwhile, thousands of veterans have passed away without ever seeing that facility they were promised. And I know the VA has been really responsive on this, your team, yourself, on trying to get this facility built. Seems like it's making some progress, but very little. What do we need to do to fix this so we never see this type of situation again? I mean, the cost, especially with the lawsuits, the way these are playing out, this gentleman is now being paid an astronomical lease payment, and he's essentially funding the attorneys to sue the federal government to continue this fight longer. What do we need to do in Congress to fix this so we never see this situation again?
Yeah, so right now, as I understand the case, and I just brushed up on it in the last couple of days, is now it's in the state court, and I think it's at its penultimate or last step. And unfortunately, we have so limited ability to influence that other than to make our arguments in the court. So I'll make sure that we scrub this down and see if we can come back to you with policy recommendations that that you could take. But I think this is a very unique case, very frustrating case. I know one that you and I know the speaker too have taken a personal interest in, and we're staying on top of this as much as we can. But in this case, people are exercising all their options.
No, and I know you've worked with us on this, and I thank you for all your efforts on this and your team. They've been very responsive on this front. It's frustrating to see. And I know Ms. Lee brought up some of the VA hiring processes. We kind of had the same type of situation in California. We had a hospital that closed their doors, a private hospital, and what we were hearing from some of our locals is the process was really slow, and it affected our ability to hire people at our Fresno VA. And so that's an issue that I'm glad it was brought up.
Yeah.
I just wanted to make sure you knew that.
We'll stay on top of it.
Also an issue for us as well in California. Rural health care. Rural veterans often face difficulties getting to their doctor's appointments. What is the VA doing to expand telehealth services and mobile health clinics to provide health care to rural communities? Do you think any of these alternatives to health care delivery methods could also play a role in helping alleviate ongoing staff shortages?
Yes. We're very proud of the progress we've made on telehealth. We've seen a 3,000% increase in the access to telehealth since the start of the pandemic. It is increasingly the first choice for veterans, not least because it saves them the hassle of travel. And we are ensuring that our infrastructure supports that. I'm particularly proud of our regional support hubs that allow us to access excess capacity in other parts of a VISN, for example, and through telehealth, shorten wait times for veterans elsewhere elsewhere in that VISN using telehealth. These regional hubs have proven themselves to be super successful. We're hoping that Congress can give us some relief on one of the big challenges we'll face post-May 11, which is our ability to prescribe across state lines certain pharmaceuticals will be directly impacted, putting at risk the prescribing authorities for as many as 40,000 vets in the country. Mm-hmm. So we're going to need legislative relief on that. Each of these things, telehealth, that includes video health, and then obviously even in some cases telephone-based care, is here to stay, and we're increasing our capacity to do that, and it is helping us ease the unevenness and access to care as a result of staffing shortages.
All right, thank you. I'll change a little bit on topic here. Last year, I became aware of a crematorium having the remains of several unclaimed veterans in storage. It wasn't until a local nonprofit group got involved that these veterans were finally given a dignified burial service. A 2021 VA Inspector General report provided several recommendations for the VA to ensure a proper burial of the unclaimed veterans' remains. Specifically, the report recommended the VA designate a senior accountable official or program office for the full scope of benefits and services provided on behalf of the deceased veterans whose remains are unclaimed. Was this official or program office ever designated?
Yeah, so thank you for your personal attention to this. This is a really heartbreaking case, but the VBA will lead the enterprise-wide program, and they have named Kevin Friel, who is the Deputy Director of the Pension and Fiduciary Service, as the senior accountable official.
All right, well, thank you, and I yield back the rest of my time.
Thank you.
Thank you, Mr. Chair. Thank you very much, Mr. Secretary.
Nice to
It's
see you.
nice to have you in front of our committee, and I really appreciate your answers that you've been giving this morning. It's certainly all issues that are critical to the veterans in our state and many of the issues that we're facing. But I do want to say in a very positive note, the CBOC in Portland, the facility that we were finally able to see completed, is really such a high-quality facility. It's so well
People
designed.
are really proud of it, it sounds like.
Yeah, I invite you to visit anytime. Get a lobster roll while you're up there. You know, it's not a bad visit. But really, it is sort of, when I hear people talking about the delays and waiting, you know, everyone waits a long time for their facility, but it just is so well designed. And I'm glad to hear you're talking about the hiring issues. Certainly, these cuts that we've heard talked about would, as you've really articulated very well, would have a huge impact on that. But that was, of course, the biggest thing that we heard about. You know, look at all these wonderful dental stations, but how do we fill it with hygienists? You know, where are the nurses? Where are the doctors? So the work that you're doing to fill those positions is critically important, and we want to
Thank you.
support you in any way that we can there. I'm going to ask you a very, you know, somewhat of a isolated kind of question, but it hasn't come up today, and it's an issue I've been working on for a while, and that's this whole issue related to food as medicine.
Yes.
You know, we know that so many of the diseases that impact our veterans in particular are diet-related diseases. We know that the hunger level in the veterans community is still way too unacceptably
Heartbreaking.
high. And we had $2 million over the last fiscal years to support some of this work. It's been a priority of the White House since the White House Conference on Hunger, Nutrition, and Health. And I'm interested to know how the VA is doing with the produce prescription program. There's a new Office of Food Security. Just thinking about food pantries and produce prescriptions, the things that we can do to help veterans, frankly, stay out of health care, not need the expensive medication or hospitalization. What are we doing, and how's it going? It's
Yeah.
new money, some of it, and I'd
Yeah,
love to
well,
hear.
we're really excited about it, and you know, the president is pushing us. You're pushing us. We feel very good about the Office of Nutrition Security, and so I think we've invested well the first tranche of money here. But you see its impact in a lot of different ways. In the first instance, obviously, we are seeing a significant increase in the use of prescriptions for food. At every VA facility now, there is also a food pantry. Over and above that, though, VA clinicians are innovating. So it's dietitians mostly leading the charge, and I now make it a habit to sit with the dietitians at almost every stop. But they're leading not only the other care providers, but they're also working with the recreational therapists. So in a lot of our community living centers, for example, we're using gardens, elevated gardens, other kinds of gardens to increase, movement and recreational and occupational therapy options for veterans. So it's actually providing, I think, what you anticipate in the first instance, which is a focus on nutrition as a good preventative intervention, but also then being used by other specialties in the hospitals to increase veteran mobility, to increase veteran mental health. We're pretty excited about it.
That's great. Well, I know, it's not an area that we give a lot of consideration to, but certainly we're looking at pilot projects at the Bureau of Indian Health. I know Representative McGovern has one related to Medicare in general, but the statistics are very good. When people go home from the hospital with diet-related diseases, and that can be, diabetes, that can be high blood pressure, heart-related issues, if they have those produce prescriptions, which basically make sure that people get healthy food in their diet once they get home, they're much less likely to have recurrence of the problem or come back to the hospital.
Yep.
So it's really got long-term benefits. It's something we often leave out of healthcare. So I appreciate the work that you're doing, and I'll
Good.
continue to follow up on it and continue to support it. So with
Thank
that,
you very much.
I yield back.
Thank you, Mr. Chairman, for holding this hearing, and thank you, sir, for your service to our country.
Yeah.
Appreciate working with you. You've done a lot of great work. I want to start by thanking you with the El Paso VA clinic. We've worked hard on that. We've gotten $700 million appropriated for that. It's exciting to see that develop it. So I'm going to ask, what's the status? Are we still on track for 2026 groundbreaking, or what's the current status of that?
Yeah, we are, and we'll go to, I think, award the contract by December of this year.
Great.
So we're still on target on that. So that's the next milestone, but everything looks in place for that, and we'll stay in touch with you on it.
Appreciate that, and you know how important these areas that we really haven't that have been put at the wayside for a long time.
Exactly.
Appreciate your energy towards that. I know it's not easy getting the money, and then I know it's not easy appropriating it and getting it built, and then ultimately when you get that first patient through. My next question is on the PAC Act. Once again, another just amazing piece of legislation that I think is starting to change a lot of people's lives. I'm an Iraq and Afghanistan veteran. My wife is a Iraq veteran. My brother is an Afghanistan veteran. So this hits home in more ways than one. I know you've spoken about it earlier, but the proof is in the pudding.
Right.
To me, numbers don't lie.
Right.
Do you, by chance, know how many veterans have successfully completed a claim that is associated with the PAC Act?
Yeah, as of last Saturday morning, claims associated with the PACT Act are about 425,000. The grant number on that, the overall completed claims, I don't have at the tip of my tongue here, but I can tell you that we're granting at a rate of about a little over 80%, 80.2%.
Wow.
Which is the strength of the presumption that you all put into the PACT Act. It just makes the process much cleaner, much shorter, much more transparent. And so we feel pretty good about that. Overall, claims year on year are up about 27%. And then right now, claim completion is at as fast as we've ever seen. That said, the backlog is starting to creep up. The backlog of overall inventory of claims is not just PACT Act, but everything, is about 208,000. It's a little less than we would have anticipated by now in terms of our assessment, but still high. But the more people we train, the more automation we deploy, the quicker we're going to get that number back down.
I mean, I will say it's always fun to go to the VA and spend time at the VA, but it has been, I think, more fun or less painful, however you want to look at it, recently. I mean, I get that from my constituents. They're saying something is working, so grateful for that. I can't let you leave without a cybersecurity question. So just last month, the GAO report came out with supporting findings for the agency-wide cybersecurity program that met the requirements of the 2014 Federal Information Security Modernization Act.
Yes.
Your budget request amounts to nearly $1 billion for cybersecurity. Can you assure the committee that by this time next year, the VA will be in compliance with this act?
Yeah, work. So FIMSA, as we call it, is a major requirement for us. So we are working aggressively to make sure that we're in compliance with that act. I want to just amplify this, and you know this better than anybody, but sometimes I worry that PHMSA is a box checking requirement. We just have to be much more agile to think that, hey, once I've checked the block, I don't need to worry about it. So we're very invested in the zero trust architecture. We're working very closely with the interagency here. We feel like we're leading the way on making sure that we don't trust any exterior perimeter. We have to just be solid at every workstation. So we're leading the federal government in terms of use of multi-factor authentication. We take this really seriously. So we'll keep working that PHMSA, those PHMSA requirements. But that's a 2014 statute, right? And I think we've gotten smarter since then. So we'll do our job on PHMSA, but our job means PHMSA Plus. And PHMSA Plus means getting serious about the zero trust architecture. We take that very seriously. That's why it's the big, cyber is the biggest component of our OI&T request here. And if we get that funding, we'll keep it in these targets.
Appreciate you making a priority. Please work with us. Anything I can do to help on this front, thank you. And Mr. Chairman, I yield back.
Great.
Thank you very much, Mr. Chairman, and good morning.
Nice to
Mr.
see you, sir.
Secretary, and thank you so much for being here. And let me hasten to thank you for all your help and support in opening the CBOC in Columbus, Georgia, and coming down and help us cut the ribbon.
Thank you for letting me be there
That was a long
on
time
celebrating
coming.
everything you did. And somehow I got the credit for everything you did. So
Thank you very much on that. But let me just emphasize and lift up the comments that you made with respect to the impact that the proposed cuts, either reverting back to the FY22 funding levels or reducing the budget to 22% of the current budget, the impact that it would have on the services and the benefits that veterans are getting access to. And I think that Ms. Wasserman-Schultz and Ranking Member DeLaura really hit that pretty hard. So I'm going to be a little bit more provincial and go to some of the issues that have been raised by my caseworkers, particularly with respect to access to medications. Apparently, the timely processing of prescriptions and availability of essential medications for our veterans has been a problem, and it appears to be recurring as I hear from my caseworkers. We have issues with the pharmacy network and reimbursement. Can you tell me if the VA has a plan to expand the TRICARE pharmacy network to better provide access to in-network pharmacies for veterans? And what is VA doing to simplify the reimbursement process and to reduce the delays in reimbursements for out-of-network pharmacies? And of course, with mail order pharmacy services, what is it that you can do? What are you doing to ensure that the mail order pharmacy issues don't negatively impact medication adherence and health outcomes for veterans, particularly our rural veterans? And the final question that I have, which has come up with respect to my caseworkers, is can you kind of discuss the current process for handling claims after a veteran's death and the difficulties that the widows are facing in filing substitution claims? What changes is the VA considering to make the substitution claim process more accessible and less emotionally challenging for surviving spouses?
These are excellent questions. On the access to pharmaceuticals, both in terms of simplifying, making more transparent how in-network pharmacists can get more quickly reimbursed, and then making it the same process more transparent for out-of-network pharmacists. I confess that this is the first time I've heard issues on that. So what I'd like to do is just make sure that out of this hearing, I get our team connected with the right person on your team, your caseworker, so we can find out precisely what's happening. because I haven't heard that as an system-wide issue. So there might be something specific in Georgia that we can address. So that's point one. Point two, on the by mail, one of the reasons we like the by mail process, it's pretty efficient, very cost efficient, but it also doesn't require travel or other challenges for many of our rural vets, which we have seen impacts adherence to pharmaceuticals. So
The
again,
issues with the post office, I guess, huh?
yeah, well,
Postal Service.
it can be, but as a general matter, we feel pretty good about what we've experienced. But again, this is why the second thing I'd like to do here is to make sure that we get with the same caseworkers to identify particularly what's going on. Is it a delivery issue? Is it an application issue? Is it, a renewal, a prescription renewal issue? And we'll get to the bottom of it. Third, on claims for survivors. You see, I think you'll notice that we talk all the time now, not only about veterans, but we talk about veterans, their families, their caregivers, thanks to your generosity in the caregiver program, and their survivors. It is simply a fact that we have to do better, and we have identified this fact. We have to do better with our survivors. The claims process is sometimes overbearing. I think too often we as VA are focused on our inputs, meaning what do we do for the veteran or the survivor, rather than what is the experience that survivor is having and whether that survivor is getting what he or she needs. I've seen this personally myself, and including with a Gold Star mom and a Gold Star wife. We have a whole team that's working this across each of the administrations so that it's a simple crosswalk between VHA, where a veteran may die in our facility at end of life, connecting that survivor to VBA, where that survivor may not know they have access to benefits, and to NCA, where many times survivors don't even know that there's a burial benefit. We just have to be a much better integrated agency that answers all those questions. So we feel like we're making progress here. We'd be happy to talk your team through this integrated team now and how those claims should get worked. And we'll see if the advancements that we think we're making are actually being felt by the survivors.
Yeah, and I get that a lot from widows. When I am at an event, they'll come up and said, your office was working well and we were getting good support from VA with my husband's claim, but he passed. And but now, we're at a dead end. I'm trying to get my benefits and et cetera, and we're just not getting the kind of help that we need. So what can you do? What can you put in place to really facilitate that transition?
Right. Well, so what we have in place now, so one thing just earlier this week, or maybe it was last week, we published a new application for pension and for survivor benefits, which we call DIC, for the PACT Act. So that process is now out there. That should be more simplified. We'll get that to your team so that they see that. But on that scenario, let's say a surviving spouse comes in and sees you and says, hey, we were getting this benefit and now we don't know what is happening. We take great pride in the fact that we send a package to that family within 10 days of the death announcement.
Within what?
Within 10 days of the death announcement. But my question to our team is, well, it's great that we send it, but what do we do to connect directly with the family? Because I looked at the package. It's 15 pages, 8 pages of instructions. And that means 7 pages of filling out. If I got that in the mail and I was grieving the loss of my spouse, I know what I'd do with it, right? Generously, I'd recycle it. I'd probably do something else with it. So we have to get better at not just sending things to people, but actually engaging them as our customers.
So So engaging them actually will require interactive interaction with personnel.
Yeah, we just had to call them.
And if you've got these budget cuts looming, you will have to reduce your personnel or not have sufficient personnel to address it.
That would be one of the impacts, yes,
So that will be another impact
Yeah.
of the budget cuts.
definitely.
All right. Thank you very much, Mr. Secretary. Mr. Chairman, I yield back the
Sir,
time that I may or may not have.
let me just say, I'm sorry to interrupt, Mr. Chairman, let me just say that I know you're a Vietnam-era vet. Today's National Vietnam War
Yes, it
Veterans
is.
Day. So I thank you very
for your
much.
service. My turn again. The fiscal year 2023 Milcon VA Appropriations Act clearly expressed that the intent of the Toxic Exposure Fund is to pay for new costs associated with implementing the PAC Act and to supplement rather than replace prior funding for toxic exposure-related health care benefits, health care and benefits. Despite this, FY24 budget proposes to realign $14.7 billion in health care costs from the discretionary to mandatory side and request several billion in non-medical mandatory funding. Can you please outline the incremental costs that will be incurred by VA for implementation of the PACT Act? And why did the administration choose to shift funds and not stay true to the intent of the law?
Yeah. Chairman, thank you very much for the question. You know, the statute, the PACT Act, and the created the TEF, the Toxic Exposure Fund, and expressed very clearly that the TEF can be used for any incremental dollar above the FY21 baseline for toxic exposure care or for benefits. And so that's precisely what we do in our requests, only what the statute allows us to do. Now, it's conceivable to me that you all will have questions about our methodology, meaning as you've just asked, how do we parcel out exactly what is toxic exposure-related care, what is toxic exposure-related benefits above the FY21 baseline? And we've already begun those conversations with your staff to explain those. These are the conversations I'm also having with the Inspector General, for example, to know that, to make sure that he holds us to account on this. But we're not asking anything that's inconsistent with a statute. And in the event that, as we work out our methodology, you guys see a better way to do it, we'll be all ears on that. But we believe strongly this is a revolutionary piece of law that you've passed. It does really important things for our veterans. It requires us to use this fund, and we're using it fully consistent with what the statute envisions, I believe. And we'll continue to hold ourselves to account and deal transparently with you guys on that.
Ms. Wasserman Schultz.
Thank you, Mr. Chairman. I'm just going to continue that same
Yeah.
line of questioning because I was going to ask you to share the methodology that you
Yeah.
used in determining the number, 20.3.
Yeah.
And, the distinguished chairman mentioned, you chose to shift costs into the mandatory, fund inconsistent with the law. That's not my understanding of what you've done. So can you specifically, knock down or
Sure.
dispel the concern? Because my understanding is that your application of the use of the TEF is directly consistent with the law.
So one example that we've heard some concern with, I heard about last week, is the second bite for 24, which are appropriated discretionary dollars. We rescind those in our budget request for next year. And we take that and apply it to mandatory. So I get why that appears to be us rescinding discretionary dollars and turning them into mandatory dollars. But what in fact we did there is what I call TEF for TEF, meaning the statute, the PACT Act, envisions the use of TEF for care for toxic exposure benefits or care for veterans. And so when we rescind that medical account funding, we rescinded it because we assessed that and we have established that that will be care for veterans who are exposed to toxic exposure, who have suffered toxic exposure. So it would be inconsistent with the law for us to maintain that money as discretionary. So in fact, to follow the law, we need to rescind it and then put it, as I say, TEF for TEF into the mandatory TEF account. This has nothing to do with, easing pressure on the discretionary account. I am worried about that, but that's why we proposed the third budget category that you and I have talked about, that all of us have talked about. What we're doing with that rescission of the second bite, by the way, you guys don't love second bites anyway, but by rescinding the second bite, we're just trying to do TEF for TEF, which is again what the statute envisions.
And I mean, I think the second bite emphasis is an important point. I mean, we're really the only bill where we have the so-called second bite, and that was to address, outlaying expenses,
Right.
so that you could make sure they decided this occurred years before we all got here. It was designed to be anticipatory in terms of the expenses and items that would come up that would be difficult to fund, newly in each fiscal year. And as I said in my remarks, I mean, the TEF funding that you're asking for includes claims processors,
Right.
current, necessary. You have to hire those in order to be able to implement the PACT Act.
Right.
Appeals. We're going to have appeals directly associated with the PACT Act currently, not, appeals that are old,
No.
that were previous, but new ones. Critical research. There's research that's going to have to be done because obviously we have question marks over the kinds of things that are going to be covered. IT investments that have to be paid for that are newly related to the PACT Act implementation, and then, of course, the healthcare costs.
Right.
So is there anything in your proposal for the $20.3 billion that you are asking for in the TEF this year that is shifted from somewhere else? I mean, other than that you're repealing the second bite, which actually is a benefit and a more straightforward way of appropriating.
Yeah, and I think the budget justification and then the subsequent briefings that we've had with your teams are meant to get at this. The only dollars we put in the TEF are dollars that, for all of the purposes that you've just laid out, are directly accountable to the PACT Act expenditures. It is a revolutionary
Newly.
over the FY21 base. Right? And so we're doing only what the statute envisions, only what the statute involves. And look, I think the reason that the TEF is in there is because I think it is a recognition that is a revolutionary new piece of law. And implementing it will require us to use this new tool. And so we use the tool, we use it transparently, but there's not a dollar that doesn't meet that requirement in the statute.
And just, Mr. Chairman, if you can indulge me in my last 11 seconds, I'm very supportive, as you know, and I have did it last year as well, for the third budget category for the VA for medical care. I mean, I've been saying since the passage of the Mission Act that we had healthcare costs growing too quickly to account for them with non-defense discretionary top lines. So I'm glad to see that in the budget. But can you explain, because I think we need the TEF and we need to break out VA medical care as a third category. So can you explain how the third budget category protects veterans compared to maintaining the funding within the non-defense discretionary category?
Yeah, so thanks so much. As long as we retain the medical care account, where it is. It is going to come under additional pressure from the rest of the discretionary account. And I guess that's understandable because the healthcare demands that we have, which is, as you said in your opening comments, increased reliance on VA. When 50% of our patients are 60 years old or older, which is the period in life associated with the highest costs of medical care. And while reliance among that cohort is increasing, overall, we're going to see healthcare inflation. So it's really important for us to protect our ability to provide that care, to establish this in a third budget category. Relatedly, our veterans rely on other facets of the federal government and the federal discretionary account. One example I gave earlier is HUD. Jointly working with HUD, we were able to permanently house 40,401 veterans who had been previously homeless just in the last calendar year, in calendar year 22. If we continue to see the growth of the healthcare account the way we are, and have it continue to crowd out investments like the importance of housing for veterans, that's going to put at even greater risk the health situation of a significant quantum of veterans. A veteran, so we still have about 36,000 homeless veterans in the country. With significant changes in the economy, we're obviously focused very much on prevention. We think we've prevented about 1 million veterans and family members from being homeless in the last 13 years. If that continues to be the case, we're going to continue to need HUD dollars in the discretionary account. So that's an example of precisely what I'm talking about.
Thank you, Mr. Secretary. I yield back, Mr. Chairman.
Mr. Chairman, I just want to make sure I missed an opportunity to raise two issues with you earlier on waste, fraud, and abuse. One is that we are working with CMS right now on an agreement to detect and recover payment of duplicate claims. So we think that we're going to be able to have a potential savings of at least $30 million a year over the next several years on those duplicate claims. Second, on vacant and underutilized property, about 4% of our owned buildings are designated as vacant with an annual operating expense of about $1.6 million. So we're working aggressively to get rid of that. In FY 20, 21, and 22, we disposed of 167 buildings that totaled about 1.17 million square feet. So we are constantly looking for ways to reduce costs, reduce outlays. And those are just two more examples that I should have raised when you asked this earlier.
Rutherford.
Thank you, Mr. Chairman. Mr. Secretary, great to see you. And listen, I'm going to ask like 3 operational questions.
Good.
So I don't. It may be informative. I don't know if you'll have an answer or not, but
Okay.
I'll bring it to your attention anyway.
Great.
One is on the Veteran Transitional Assistance Grant program. We finally got that law passed. Veterans Armed for Success in 21, and I'm told that the rule writing is about over, and we're actually going to be ready by October of this year. Do you know if that is on target to actually happen?
Let me, it is, but I want to get the exact answer for your question here because I have it, because I was just studying it last night. And,
Okay, because this, Mr. Secretary, is going to help with your homelessness,
no question about it.
because we'll keep people employed.
Yeah. So we're currently on target for full implementation first quarter FY '24. We requested an additional $5 million this year in this budget for the
Right.
program. That includes a request, that includes the ability to hire 3 new employees and then to administer the $4.5 million in the first quantum of grants. So we're hiring the staff. We've established a grant management office. We're working on a technology solution to run this. And this means that we should be in a position to make sure that the first grants are made first quarter FY24.
Okay, thank you. That's a little later than I was hoping, but
Yeah, you and me both.
that's
Yeah.
okay.
Yeah,
Because it really is going to help.
I agree with you.
Keep a lot of these
I agree with you.
fellows employed and ladies as they transition. The second one, we are still experiencing a very large backlog on our appeals decisions. And I don't know that that's unique to our vision or not, but the caseworkers in my district are really concerned. It's back to years again.
Yes.
Can you tell me a little bit about what we might be doing to try and reduce that backlog?
This is what we're doing here is two things. One is we're just
Excuse me,
Yeah.
and is it wider than our?
It is.
Okay.
Yeah, this is a system-wide issue.
Okay.
There's two issues. One is the legacy claims, and we're working those down, but we're still too high on the legacy claims. But then the next is just claims under the new system. That as we get more decisions, but as I said earlier today, we're awarding PACT Act claims at about 80% grant rate. So that that's obviously going to reduce the number of appeals, I hope. So it's a system-wide challenge. There's two answers to this. One is more judges, more lawyers. We've been hiring aggressively judges since I arrived. We just I guess it was about 6 months ago, onboarded the next quantum of them. I'll get you the exact numbers. I don't have those in front of me. The second thing is we just have to make sure that when we schedule a hearing, we do it. Our ability now to use technology for what we call tele-appeals helps. Our ability to be more clear with our VSO partners about who's scheduled when and how means that too often in the past we'd end up, either a judge, has to change something, a veteran has to change something. Nobody gets communicated to, so we end up not using a slot.
Right.
We got to make sure that we make absolute use of
Use of all
every
of them.
slot.
Right. Okay, and I'm really concerned, looking at the PAC Act application, we're going to have all those new folks trying to come through that appeal process
Yes.
as well.
Exactly. We just got to get this right. I totally agree with you.
Okay. And then the second thing, this is really concerning to me. Our St. Petersburg, Florida regional office, for whatever reason, I'm told they dissolved their congressional liaison department. So now our caseworkers are having to go through the normal process that all veterans go through to try and get answers to questions. Those liaisons are
Critical.
critical.
Yeah, so obviously we have some kind of communication issue here, so I'm not saying everything is right. But we did reach out to them last night after we heard that you were concerned about this. They reassure me that they have congressional liaison staff, but they also use the public contact staff to assist with workload as needed. So they haven't replaced them, but we do supplement. But let me make sure that
Is their congressional liaison staff down or not?
No, it is still there. It's still
still
working. But so why don't we get the name of your person when we leave here, and let's just connect everybody and make sure that there's not any
Okay,
confusion.
perfect.
Because I don't know if I've gotten bad gouge or what. So, but we checked last night and again this morning. We're reassured that the liaison staff is still there.
Okay.
Okay.
Excellent, excellent. And, Mr. Chairman, with that, I see my time is up. I yield back.
Mr. Bishop, you have any further questions?
No, you
Ms. Lee?
Thank you, Mr. Chair. I just wanted to follow up on the electronic health record.
Yes.
The House majority has made some proposals of cutting VA funding to fiscal year 2022 levels. How would that impact the EHRM?
Well, it would be, let me just see if I have a specific number on the EHRM, but it would, it would obviously end up being, I guess let me get a specific number from you, for you, but, it's, like our third biggest outlay in our Office of, Infrastructure and Technology. So, the cut would be indiscriminate across that account. So it would have an impact on, I'd have to get you a specific number. Remember that the biggest request in that account is for, cybersecurity. And when we're increasingly reliant on telehealth, I'd be really worried about the impact on cybersecurity too.
What would these cuts do to the broader IT and other infrastructure upgrades across the VA, and what would that mean to care for veterans?
Yeah, so I'm told here that the Office of Infrastructure and Technology would have a $345 million shortfall between proposed 24 and actual 22. So that means significant impact, as we say, on network reliability, which is increasingly what we use for what I mentioned earlier is a 3,000% increase in the use of telehealth. So it would have an impact there.
Let me turn now to student veteran benefit processing. We're hearing from student veterans and universities in Southern Nevada about the transition to the enrollment manager for school certifying officials who are responsible for ensuring these veterans receive their benefits. I appreciate your team's responsiveness to my letter in December asking to delay that transition, obviously in January based on the schedule. But unfortunately, since the transition went through this month, officials at the University of Nevada have reported big complications from dual certification requirements, a VA policy that if a student has another claim in the queue, their basic housing allowance can be seriously delayed. Delaying these benefits for even a few days can be devastating for our student veterans. Do you have any updates on this rollout and VA's efforts to ensure that these benefits are delivered in a timely manner?
Yeah, so I have been tracking the enrollment manager deployment because you and a couple other members had brought this to our attention. We did make the decision, as you said, to postpone in light of the change of semester. I have not heard other examples of this, so I think the most important thing we could do is, why don't I get a name of somebody at the University of Nevada, and let's get our team in direct touch with them, and let's figure out exactly what's going on.
Okay. We'll follow up on
Good.
that. Just on mental health,
Yes.
this has been an issue, obviously, that we're all focused on. I just introduced the VA Zero Suicide Demonstration Project. This is a bipartisan bill that will deliver to the VA a proven system-wide processes for preventing suicide. So I'm being committed to moving that forward. Are you aware of this initiative?
The specific initiative that you're referring to, I don't think I am aware of it.
This is built on this belief, and it's a model that was adopted in the private sector, that all suicides are preventable with proper care, patient safety, system-wide efforts. And so
That's surely our view. So I just didn't know if there's a specific initiative, but surely that's our view, and that's what all of our programming is designed to.
Okay, well, we'll follow up on
Yeah.
that. And I just want to talk now more specifically to Vegas. At
Yep.
North Las Vegas, mental health appointments, wait times are 25 days for new patients and 9 days for established patients. You know, we can all agree far too long for anyone who's
Yes.
experiencing a crisis. Given the reality of what these wait times are now, how would you expect the proposed funding cuts, proposed funding cuts to impact mental health services for veterans?
Yeah, thanks very much. I just want to point out one thing really quick, especially for any veterans or any of you who are talking to veterans in your districts, so the wait times you talk about, if any veteran is in crisis, all they need to do is call 988 and then press 1, and we can get them into care that day. So those numbers that you're talking about do not account for emergent care. So any veteran in crisis, please dial 988 or family member 988, press 1. Secondly, the wait times in mental health care are a direct outshoot of two things. One is our ability to have MSAs, in effect, the schedulers, the real pistons that make VA healthcare work, and then mental health professionals, psychologists, psychiatrists, counselors. And we are working really hard. Those are two of our priority hiring streams. We're making good progress on both, but they require money. And if we see a cut of the type that we're talking about, that's going to undercut our ability to keep hiring at the rate we're hiring. And it will undercut our competitiveness because we're bidding for these limited resources with other hospital systems. And so I'd be really concerned about that impact.
Mr. Chair, can I ask one more question? Just one idea that was floated by some of the professionals in Vegas is this barrier of the civil servant classification that we use in the federal government being applied sort of uniformly to the VA. You mentioned trying to work around that to try to get above the $400,000 for a doctor's salary by doing some contract. Is there, have you looked at or made proposals on a potential adaptation to that schedule that we could apply specifically to the VA? Because this seems to be a different type of workforce than maybe traditionally seen across the federal. I mean, this goes outside of our jurisdiction, but something we could work with oversight on.
Well, first, I'm not surprised to hear that, Bill McCarran and his team in Las Vegas are coming up with creative ideas because they're a great team and very creative team, one. Two, one of the complications we have in hiring is that we can hire across 3 different systems, Title 38, Title 5, or Title 38 hybrids. So we have different flexibilities associated with each of those. And so it really, I hate to say this, but it really depends on what we're talking about. The challenge, though, with having 3 different hiring systems is that it is an administrative burden on top of administrative burden. So, we've talked about whether we come talk to you guys about, trying to harmonize that into one hiring system, which might be more akin to what McCarran and the team are talking about. I have not proposed that because, to be honest with you, it feels like such an overhaul. Like I got so much daily work to do. I feel like it's going to be a distraction. And that could be the wrong decision, but when I think about, if I make it 4 years and I don't get fired, right, then maybe you could get a start on something like that. We just need to get better at hiring than we are, period.
Thank you. Thank you, Mr. Chair. I yield.
Thank you, Mr. Chairman. If I could just ask a quick question, and it really kind of flows right into the conversation you were just having. When VA authorizing a few years back changed or allowed for the change on how we do residency and loan forgiveness.
Yes.
And the whole idea was, number one, we wanted to improve the quality of the doctors that we're getting.
Yes.
But also the quantity.
Right.
And
retain them longer.
Exactly.
Yeah.
And so instead of offering the loan forgiveness after their residence after the selection of their residency, because then they were either we were kind of getting the folks that couldn't get anywhere else, which was bad.
Yeah.
And so we tried to offer that money up front to get them to come to us
Yeah.
on their own
Yeah.
with that commitment for, I think, 4 to 6 years, something
Yeah.
like that.
The 6, I think.
Is that, have we seen any benefit to that program?
It's a really exciting program. We're just on the verge of graduating the first participants.
Oh, is that right?
Yeah, so I'll get you a summary of it. I just talked to our workforce development lead on this question. So that, plus a series of workforce enhancements that you gave us in the PACT Act, plus we're asking for a couple others that we talked about a little bit earlier to get out from under. That's okay. To get out from under a $400,000 salary cap.
Right.
Those are giving us all sorts of new competitive opportunities, and we're making good use of them, and that's why we've had the success we've had. We've had the best hiring quarter in VHA that we've had in 20 to 25 years. We got to keep that up if we want to meet our target for this year. But I'll get you the specific summary on those
I
new
would
docs.
appreciate that, Mr. Secretary.
Yeah.
And can you give me some idea about rural versus urban too, on how that's working?
Yeah, in terms of the docs in that program?
Yes.
Yeah, I will. I'll make sure that we disaggregate that.
Thank you very
Absolutely.
much.
You bet. Thank
I
you.
yield back.
Do you have anything else? All right, well, thank you. I will tell you that you have great talent.
Well,
You remain calm, and you're a good witness.
I'm just trying to reflect my chairman's guidance here.
You're a good witness, and I've watched lots of witnesses, and you're a good one. Well, if there's nothing more, we'll stand adjourned.
Thank you. Thank you, Mr. Chairman.
On the nose, man. We ended right at,
I saw that. You started right on the nose, and right on the nose.
yeah, we did.
That's my kind of meeting.
Yeah. Used to have a law professor at the University of Texas that never wore a watch, never had a clock in his courtroom, in his classroom. But he would hit the back door just as the bell rang to start the class and began talking. Walk up and down the aisles lecturing, and then hit the back door just as the
That's
and
that
they
bell
ju-
ring again.
It just freaked out the students like you can't believe.
That's a skill. That's a skill. That's a skill. Yeah, thank you. I'll follow up on these things, and I'll figure out what's going. It's clearly there's some. But they told us this morning that they have the staff, so.